Hi, my name's Christina, and I'm a PharmD candidate from UT Tyler. My patient is a 63-year-old African American male who was transferred to the ICU on 10/7/14 for penicillin desensitization protocol for his VRE endocarditis. He initially presented to the ER with a GI bleed and warfarin toxicity, and he had an INR of 11.5 and was taking ibuprofen 3 to 4 tabs for pain. The warfarin toxicity was reversed with vitamin K and FFP. The warfarin was discontinued, and he had blood cultures that showed he had VRE bacteremia. This was treated with vancomycin, then switched to daptomycin after susceptibilities returned. Once his dialysis catheter was removed, the infection cleared. He had a TEE that showed possible small vegetations, and this is what led to treating for infective endocarditis. The ID consult suggested ampicillin. However, the patient does have a penicillin allergy, and this is why he's been transferred to the ICU for a penicillin desensitization protocol. He has a past medical history of GI bleed, gout, ESRD, aortic dissection, CVA, hypertension, hyperlipidemia, AV fistula, CAD, PE, residual cognitive deficit, COPD, PVD with amputation of first, second, and fifth toe on the left foot, diastolic dysfunction, diabetes type 2, hearing loss, iron deficiency anemia, back pain, and pain in his right foot. His family history is CAD. He has a social history positive for tobacco and negative for IV drug use and illicit drug use. His allergies include lisinopril for cough and penicillin for hives. His immunization status is unknown, and his total body weight is 66.2 kilograms, ideal body weight 56.9 kilograms, adjusted body weight 60.9 kilograms. His vitals and physical exams right now are all within normal limits, and his serum creatinine increased. It was originally 2.97, but it doubled the next day to 4.31. His creatinine clearance is 22 mils per minute. His microbiology, he had a blood culture that was positive for E. faecalis, and it was sensitive, ampicillin sensitive and vancomycin resistant. He had radiology, had temporary dialysis catheter removal on the 7th, CT on the 3rd, and it showed no evidence for fractures or dislocations of the spine. His TEE on the 5th showed his ejection fraction to be approximately 60% and possible small vegetation. For the sake of time, please review the inpatient meds of the following: amlodipine, metoprolol tartrate, lidocaine, insulin, Lispro, hydromorphone, heparin, esomeprazole, darbepoetin alpha, daptomycin, beclomethasone, penicillin V, pravastatin sodium, oxycodone with acetaminophen, albuterol, labetalol, epinephrine, diphenhydramine, and normal saline. So for his GI bleed that he was initially admitted with, he currently has no further bleeding events. However, and he's taking esomeprazole 40 milligrams twice a day, but we want to continue to monitor his signs and symptoms of bleeding as well as CBC. For his endocarditis, he's taking the daptomycin 6 milligrams per kg, and he's going to start the penicillin desensitization protocol on the 9th, followed with ampicillin 2 grams IV push every 12 hours for 4 weeks, and the streptomycin 500 milligrams IV piggyback 3 times a week for 4 weeks. We want to monitor signs and symptoms of anaphylaxis during desensitization. He also has prescribed the epinephrine and diphenhydramine PRN anaphylaxis. We also monitor signs and symptoms of infection in his BMP and CBC. We also monitor peaks and troughs. He's going to be continuing hemodialysis on Monday, Wednesday, Fridays for his ESRD with 2 liters of normal saline. During this time, we want to monitor his BP and make sure that he doesn't become hypotensive. For his diabetes, he will begin insulin Lispro sliding scale. We want to monitor his blood glucose, signs and symptoms of hypoglycemia or hyperglycemia. For his COPD, he currently has no exacerbations at this time and is continuing his home medications of albuterol, 90 micrograms per puff, 2 puffs twice a day PRN SOB, beclomethasone 80 milligrams per puff, 1 puff BID. And for the inhaled corticosteroid, he wants to make sure that he rinses his mouth and does not swallow, and monitor O2 stats, exacerbations, signs and symptoms of oral thrush. For his hypertension, he's going to continue his home meds of amlodipine 5 mg daily and metoprolol tartrate 25 mg 2 tabs BID. He also has an order for labetalol injection whenever his systolic blood pressure is above 150 or his diastolic blood pressure is above 100. You need to monitor blood pressure, heart rate, and rhythm. For hyperlipidemia, per the AHA-ACC cholesterol guidelines, for patients who have diabetes and are within 40 to 75 years old, they should be placed on a moderate intensity statin. So we want to continue his home meds of pravastatin, 40 mg. At this time, we want to also order a lipid panel and LFTs and monitor his CPK because there's an increased risk of skeletal muscle toxicity when taken concurrently with daptomycin.